So I understand you are a doula.
Yes.
So why don't you tell everyone what that means?
Yeah. Okay. Great question. And I do think it's something that a lot of people maybe have heard before, but they don't fully understand what we do. We work adjacent to healthcare providers. So we are not healthcare providers ourselves. We are not going to be doing things like temperature checks or blood pressure checks, certainly not cervical exams or any sort of prescriptions. But we work alongside your OBGYNs, your midwives, your L&D nurses, your GPs, your women's health providers, and we give pregnant women and their family educational support, emotional and mental support, physical support, and this includes before labor, in labor, and postpartum.
Great. So it's all labor based. How did you get into this?
Well, so I have a master's degree in human development and family studies, and my career started in early childhood where I was in the classroom for what we call newborns, the newborn classroom, and that is throughout the first year of a child's life. And one of my colleagues said, "You would be a great doula." And I said, "What's that?" And she said, "You help people have babies." And I said, "Oh, I think I would like that." And so I took a weekend training, and I realized that it was really complementary to the master's degree that I already held, but that the training itself was quite shallow, and that in conjunction with my master's degree, I could really change the way that people birth. I could bring a whole different philosophy to the way that people prepare for labor and delivery. But when I got into labor and delivery and I started attending births in the hospital, I realized, holy cow, the system is just so corrupt almost. It's like really meant to take advantage of women. I mean, all the policies are just not written woman friendly. They're not written in a patient centered way. And it is like when women enter the system, they're put on this conveyor belt. And if you don't know any better and you don't know what questions to ask and you don't know how to advocate for yourself, then your likelihood and your chance of experiencing birth trauma is skyrocketed. And that's why our country has an insane maternal mortality rate, a really abhorrent infant mortality rate. Our trauma rates are horrible. Our C-section rate is rising. And so the more policies that we put into place, you would think hypothetically, the better our outcomes would get. But in fact, the U.S. has seen the opposite. The more policies we've put into place, the worse our outcomes have become over the last 10 to 50 years.
Take control of your own health. I am so cold. It literally feels like electricity is running through my body. I feel superhuman. Do people know about this? Because I feel like my friends, like I'm kind of in this whole space, but like my friend, no, like it feels like everyone just trusts the doctors. Like they're the best. They're highly trained. They go to med school. They give birth. Like, why would we do home births? Why would we have doulas? Like, how come? What is going on?
Yeah, I think 10 years ago when I started as a doula, it was almost this fringe idea of like home birthers have doulas and like people who want to go without an epidural have doulas. One of the really great things that happened during the pandemic was that people really woke up to the fact that the hospital system is in large part a for-profit system, and that if you're gonna properly navigate it, you have to be educated yourself and you have to have the correct questions to ask. And so that has really highlighted and put a spotlight on doulas. And so now I think people are starting to realize, wow, I do need a doula. There is a lot of information out there that I don't know. And, even the fact that one hospital on this side of the street could have a 10% C-section rate, which is really great. Mm-hmm. And on the opposite side of the street, same zip code, same population, you could have a 70% C-section rate, which is crazy. And I think the more that women start to wake up to this idea, the more you're going to start to see women start to demand better care, doula access. And then you have men who are saying, well, I want better for my wife, but I don't know what to do. And that's also where doulas can help. Doulas are a good doula will actually elevate that couple as a unit and not take the place of the husband. She'll actually help educate that husband in what is his role in the labor process and how can he be a good partner in pregnancy, and then what role does he need to fill in postpartum to make sure that not only is his wife supported, but she's thriving and that their household can keep going in a really productive way.
Yeah, that makes sense. So what's wrong with C-sections? Like, I feel like you speak very negatively about them. Why aren't they?
Yeah, well, maybe I'm sad to hear you say that I speak negatively about them. I don't ever want to demonize C-sections. What I will say is the World Health Organization says a country of our size should have a 10 to 15% C-section rate, and ours is 33 to 34%. So not only have we doubled that, but we have doubled it and a little bit more. So it's not C-sections themselves are bad. It is the way in which we utilize C-sections, right? It's the way in which there are so many unnecessary C-sections that are happening in our country, and that it has become the default for many otherwise normal births. Two that I can think of. One, twins, which many sets of twins are appropriate for vaginal delivery. But in the U.S., there are so many hospital policies and providers who will automatically tell a woman she has to have a C-section because she has twins. The second one is breech. Now, this is largely in part to the term breech trial that was published in the year 2000. And not only was it a very flawed trial, but it was actually redacted years later, but the damage had already been done. Medical schools had stopped teaching skills of breech birth. Hospitals had put policies in place to quote unquote ban breech birth. And so when we look at our C-section rate, there are some very easy, low-hanging fruit items that we could easily do in a very affordable way. Really easy to disseminate that information and put these things into place, and we just don't do them. And so instead of having an appropriate C-section rate, which is, again, about 10 to 15%, we're seeing ours continuously climb. And it does have a ripple effect. So if you have one C-section, then you are considered a VBAC next time, vaginal birth after cesarean. Not all providers are comfortable with this. Not all hospitals support or quote unquote allow a VBAC. And so that takes a woman's choice from any provider, any facility quite down to a narrowed, I have to find a VBAC comfortable and supportive provider, and I have to find a facility that allows it, quote unquote, right? And not only that, but you have to think about the physiological impacts as well. So what does that scar tissue do to her body? How does that impact her fertility going forward? How will it impact the way that she carries her next pregnancy? How will it impact the way that her placenta adheres to her uterus? What if that placenta adheres to the uterine scar? Is that a problem? And it is a lot of times. And so we have to think about that later down the line effect. And this is one of the things that's really missing in the conversations of what we call primary C-sections or a woman's first C-section.
So would you say that a C-section lowers your fertility chances for future births?
So it can. We know that depending on how that uterine scar heals, it certainly can, because it can cause what we call torsions, and that's tensions in the muscles and the tendons and the ligament. And so if a woman is not aware of or doesn't have access to, let's say, a PFPT who can do scar massage to help her body heal in an appropriate way, just as we give to athletes PT, scar healing, follow-up, there is nothing for women. And so sometimes we really do see women that have, after a C-section, their uterus is completely tilted or their pelvis is completely unaligned. And so when they do try for a second baby, their body is just not in a place to receive that pregnancy and stick with it. And so, yes, it can. It is not a surefire thing. And that is not to say that every woman who has a C-section is going to go on to have fertility fertility complications, but it certainly is a risk factor that should be discussed in the setting of a primary C-section for sure.
That's crazy. What about for the baby? What are the negatives of a C-section?
Yeah, great question. So when we're looking at vaginal birth, we know that your baby gets a lot of what we call catecholamines. And these are chemicals that are released by the woman's body. And so if we have a scheduled C-section and that woman never experiences the onset of labor, then that baby is completely robbed of being showered in those catecholamines. We also know that passing through the vaginal canal helps inoculate that baby's immune system. Not only is the mom's vaginal flora doing a large part of that, but kind of funny enough and a little awkward, but fecal matter is very much part of the birth process. That mom's fecal matter will get on that baby and help do the same thing, kind of boost their immune system or inoculate their immune system, because babies come here in a quite, they're a clean slate. I don't want to say sterile because they've been in amniotic fluid, they've been in that mom's body, but they have a very low immune system. When we take a baby out via C-section, not only do they have antibiotics coursing through their body because mom has been given antibiotics because of the risk of infection associated with a C-section, but you also miss out on the catecholamines if it's scheduled. You miss out on that vaginal flora. You miss out on the exposure to fecal matter. And then we also see some other impacts, like babies who are born via C-section do have a higher risk of a NICU stay simply because, well, there's a lot of reasons, actually. It's possible that we took them out too early, and they aren't able to actually breathe on their own, so they experience respiratory distress. It's possible that because they did not go through that vaginal canal and they went through that very tight squeezing process, they actually still have fluid in their lungs. Again, respiratory distress, so then you would need a NICU stay. Longer term things, we see eczema be connected with C-sections, and then other health outcomes that like cardiac complications, diabetes, and I believe ADHD, but don't quote me on that one.
And so these are complications that can stay with the person throughout their whole life.
Oh, yeah, absolutely. I mean, and, again, I don't want to demonize C-sections. There are appropriate times that we need a C-section. The question is this baby safer on the outside than they are the inside? And if they are, then yes, let's get them out. Thank God we have C-sections. But if not, do we have time to wait? Can we engage in maternal positioning, which means just like get that mom in a different position? Can we get her in hands and knees and off her back? Can we not induce for 39 weeks and instead wait for spontaneous labor? If it is a quote unquote failure to progress, which means this mom's body has appeared to stop working in labor, maybe we should question some other things. Is she feeling safe? Is the environment conducive? Are the people in her room talking to her kindly? Are they talking to her gently? Are they supportive of her ideas? Or is she stuck in fight or flight because she has someone in her room who is badgering her, who doesn't believe in her, who is telling her, just get the epidural, just get the epidural, just get the epidural. And she's like, I don't want it. And eventually she's just like, fine, just give me the epidural. I'm tired of fighting with you, right? Labor should never be a fight. And there's a lot of times where we do have to fight. There's even situations where women are forced into certain things. So they tell their provider for many weeks, I don't want an induction. I don't want an induction. I don't want an induction. And then lo and behold, at 39 weeks, they agree to an induction because their provider has used fear-based or coercive care in order to get them into an induction. And now they've come into labor completely activated, very fight or flight, totally scared and unprepared for this process because they were focused on waiting for spontaneous labor.
So why would a provider want to induce a labor?
Well, there's a lot of reasons. So if there's a cynical side of it, and then there is a maybe more realistic side of it. So
let's start with the cynical side. Yes.
Yeah. So the cynical side is money, ROI, pleasing investors. It's easier. The hospital can control it. If you can schedule when a woman's coming in, then you know exactly how many beds you have filled at any given time. Whereas if you wait for spontaneous labor, you may have a day where you have 1 or 2 births, and then on, let's say, a full moon or a thunderstorm, things that we know that impact the barometric pressure are going to pull out babies because we're full of water in there, which is a lot of people don't realize that. But snowstorms, tornadoes, hurricanes, thunderstorms, any sort of big, huge shift in the barometric pressure will cause labors that are already ready to go into labor. And so let's say you have a snowstorm. I'm in Boston, so snowstorms are kind of notorious for overfilling L&D, and you may on any given night have 15 women go into labor. That is really unpredictable, and the hospital system does not like unpredictability, right? They love to be able to schedule things. And so based on the ARRIVE trial, another study that is incredibly flawed and has been not redacted, but debunked, and there have been several other better studies published since the publication of the ARRIVE trial. The ARRIVE trial really got disseminated very quickly, which is really odd because the data shows that it takes about 17 years to get good data out. So why did the ARRIVE trial get disseminated across the healthcare system within 2 to 3 years? Because of confirmation bias. It showed those providers what they already thought was true, even though it was an incredibly flawed and biased study. Now,
so what exactly, could you explain the study a little bit better?
Yeah,
I just didn't really understand like what it actually is.
Yeah, so the ARRIVE trial looked at what we call expectant management of labor versus active management of labor. And so expectant management is waiting for spontaneous labor to happen, and then we let labor go. Active management is we induce women and we try to control the way in which labor transpires.
Right.
Now,
so that study said that when you control labor, it leads to better outcomes. I guess, is that what you're saying?
Yeah, they said that it showed a reduction in C-section, but there's quite a number of flaws in this. Number one, and probably the most concerning, is that a little over 22,000 women were asked to participate, and just a little over 6,000 did, which means a ton of women saw when they were presented with the study, I don't think this is for me, okay? So it takes a very special type of mindset for this study to be applicable to you. You have to be open to induction, and you have to be open to the way in which your hospital is going to induce. And I say that because the study had no standard method of inducing. There was nowhere in the study where they said, these are the steps that we use to induce these women. And that is because every hospital included in the study used their own methodology. And so how can you take a study that used tons of methodology and then apply it and extrapolate it to a large population? You can't. So those are the first two flaws. The third flaw is that, and this isn't necessarily a flaw, it is more of a representation, a misrepresentation of what the study resulted in. They said that it reduced the risk of C-section dramatically. So it was totally safer to just induce, where in reality, it's about a 3% reduction in C-section rate. So some people would call that negligible, right? If we saw a 3% in reduction risk in death based on a certain medication, I don't know how many people would say, well, give me medication A versus B, right? If you are talking about a 3% C-section rate, reduced risk of C-section, a woman who is really committed to unmedicated spontaneous labor probably will not think 3% is that much, especially considering that your risk of C-section with induction increases by 31.9% just by way of induction. So you are trading 3% reduced risk in C-section for a 31.9% increased risk for C-section just because you were induced.
That's crazy. And
The balls are definitely there.
yeah, I mean, and like you said too, I mean, it's also like, yeah, it's the type of women that would even do this study. Like they're willing to be induced. They obviously have tremendous amount of trust in the system to begin with. They don't
Really.
like they're willing to get induced.
Or they want to be induced, right? So I think this study also highlighted a really important thing that not a lot of people talk about, and it is your mindset going into labor. So if you go in and you're excited about your induction, you agreed to it, you want to be induced, you are not going in with high cortisol, high fear, stuck in fight or flight. You're going in with oxytocin, excitement. You're ready for this. You are eager for this. Of course your labor is going to go better. But for women who feel forced into that decision and backed into a corner, they are coming in high cortisol, high fear, stuck in fight or flight. Of course, we're going to see their bodies not respond well. It's a physiological process. And now they're up like this. They're trying to fight their way out. We will never see labor get going like that. Labor is based on safety. A woman needs gentleness and groundedness, calm space. They need to feel supported and loved and nurtured. We want natural oxytocin flowing, and it's just impossible to have that when you're stuck in fight or flight and you feel forced or coerced into a decision that you didn't want.
And what exactly is inducing labor? Is breaking the water, Pitocin, all of that is in the bucket of
Great
induction?
question. Inducing labor is essentially putting a body into labor that was not ready to be in labor. Because if the body was ready to be in labor, it would be in labor. One of the most accepted theories that we have around what initiates labor is a chemical called a surfactant that is emitted from the baby's lungs that mixes with amniotic fluid and then gets contractions going by releasing oxytocin in the mom's brain. So the thought is if that baby's lungs were ready, they would emit that surfactant and labor would get started. Now, when we induce, you have a couple of different ways that we can do this. First, we want a really nice and squishy, thin cervix. It's called effacement. And so we have drugs that go vaginally, like Cervidil, Cytotec, Misoprostol. And some of those are the same, but just under different pharmacological names. Then you have things like a balloon, which is a mechanical ripener. They're going to stick a balloon through the cervix and they fill it up with saline, and then it pulls mechanical pressure down on that cervix to dilate it. Then you have breaking the waters, which is a dose of oxytocin, but ACOG, the American College of Gynecology, they actually recommend not breaking the waters. They recommend against breaking the waters, which is called amniotomy. And they say that amniotomy should be reserved for really intentional cases and scenarios. And then you have Pitocin, which is obviously that lab-made synthetic version of oxytocin, and ACOG, the American College of Obstetrics and Gynecology, have a loose way of guiding people on how to use Pitocin. And so every hospital has different protocols. Every provider has different preferences in which they use Pitocin. Now, one thing that's interesting is that the FDA actually does have a protocol, and they say that once a woman is in active labor, we should turn the Pitocin off and see if her body can take over. There are not many hospitals in the U.S. that actually follow what the FDA guidelines say about Pitocin use.
Right. And yeah, like you sort of said, I'm definitely under the impression that every single intervention in a hospital leads your chance of increases your chance of C-section. That obviously includes Pitocin, right?
Yeah, I mean, I think it's situational, right? So if we have, let's say we have someone who has transferred from a home birth and they've been in labor for 4 days and they are extremely tired and there's no way they are going to be able to push a baby out for more than 20 or 30 minutes. It is appropriate for that person to opt for an epidural to get some rest, to rest their body. And then if that epidural slows down their labor, it would be an appropriate conversation of whether or not low dose Pitocin would be a good idea. In that situation, the question is, do we have a higher risk of C-section because of maternal exhaustion because she's been in labor for 4 days? Or do we get her an epidural and give her some low dose Pitocin and then help her have a vaginal delivery, right? We've got it. They're all tools in the toolbox. And so I think a lot of times these things can be demonized, but it's not the tools themselves. It's how we use them and how often we use them inappropriately that increases your risk of C-section.
And everything that you give to the mother, you're essentially giving to the baby. So if you're going to give Pitocin to the mom, that is affecting the infant, correct?
Yeah, you want to look at whether things are going through a blood-brain barrier. So do they cross the placenta? Pretty much everything does. How much it does varies. So we know that an epidural does get to the baby. That's why we have an increased risk of respiratory distress afterwards, although it is lower than Pitocin gets to a baby. However, when you start to administer Pitocin, you do have that risk of fetal distress, so funky fetal heart tones where your baby just cannot tolerate it. In that situation, a lot of women don't know you can turn off Pitocin. So do you turn it off? Do you turn it down? Or do you just continue with Pitocin? And that is known as pit to distress. So we're giving so much Pitocin, we're leading that baby to distress. And that is how you end up with an unnecessary C-section that could have been avoided had we turned off Pitocin or had we turned it down and allowed that baby some time to acclimate to those stronger contractions. But yeah, you're right. Pretty much everything we give a mom in labor is going to that baby.
So just to reiterate, the Pitocin will raise the baby's heart rate?
It can, yeah, absolutely. It is one of the side effects that's listed in the manufacturer inserts.
Right. And then you have the doctor saying, oh my God, the baby's heart rate is increasing, failure to progress. We need to move this thing along. C-section.
Correct. Your baby's not tolerating labor, which it's not that your baby's not tolerating labor. Your baby is not tolerating that dose of Pitocin. And so that's why we want to have the conversation of, well, should we turn it down or should we discontinue it altogether?
Right. And back to the cynical stuff. Is there more money to be made in C-sections?
Well, of course, right? So when you have a surgery, it's always going to be paid out more than a vaginal birth would be. And you have some people who criticize the healthcare system and say that we should actually be incentivizing vaginal births over C-sections instead of incentivizing one birth over the other. I have this really wild idea, and I have for many years, that we could actually use a algorithm that looks at the population of a certain hospital and says, because of this population that you serve, because all populations are going to have a little bit of a different, risk factor and need a little bit different support, your C-section rate should be this number or below. And for every C-section that you do over that, there will be an investigation and you will have to justify why you did that C-section. And if you are found to be negligent in doing C-sections unnecessarily, not only will that hospital be penalized, but so will the providers who are doing the care. And it's very unusual. I am not a very punitive person, but I do believe that incentivizing providers and hospitals I think that's a large part of the problem. So I think it doesn't make any sense to shift from incentivizing one thing to the other. We've actually got to really walk this back. And unfortunately, punitive practices are appropriate in some places. And I think this is one of those.
Yeah, yeah. I mean, and just in general, like you sort of said, incentives are weird where it's like, there's vaccine incentives and all these other incentives, but then you're like, oh, well, what if you incentivize the other way? Then people would say, oh, well, then maybe they'll be dangerous and they won't do a C-section when maybe they should. So I guess maybe my solution would just be like, every doctor should have their C-section rate just like posted to their name. Like, this doctor has this C-section rate, this one has that. And then maybe a reviewing system. Like, how come every other business in the world, there's just like reviews and you can't delete them? And maybe like the business owner can respond to reviews. So like maybe the patient's not happy, but they leave a bad review. Then maybe the doctor chimes back and says, well, this is why we had to do that. So then the people can decide.
Totally. I love that. And, we've got some leaders in that. Ironically, California, for the state that it is, it's doing a really great job in this. It is actually leading the way. They've got some initiatives out there that have shared C-section rates. And you know what they found? Their C-section rates went down when you started to publicly post a doctor's C-section rate. Doctors stopped doing unnecessary C-sections and they saw drastic differences. So I could not agree more. I think that's a great idea.
Yeah. And it is interesting because I think that like maybe in the 90s or something, there was this like push where like celebrities were getting C-sections and it was like the cool thing to do, like plan your birth, get your C-section. So it's almost like for a moment there, they were seen as totally positive and it was like, oh, you're not getting a C-section?
Yeah, I mean,
what do you think happened there?
Well, I mean, I think a lot of that was just propaganda from the hospital system. We saw the same thing with midwifery care. We saw the same thing with home birth care. So, 90% of births in the U.S. used to be done at home. And then Rockefeller Medicine took over and said, oh, well, this is very dangerous because we can't make any money off of it. So if people are birthing at home with midwives outside of the system, how will we monetize that? And so they started to truly demonize midwifery care. They started to make it illegal. And we still have states in the U.S. where it is quote unquote illegal for home birth midwives to practice.
Wow.
And then you started to see this massive shift into the hospital. And then beyond that, you started to see epidural rates rise. You started to see NICUs pop up everywhere. And now we have NICU entrances rising. And now we have C-section rates rising and our maternal mortality rate is rising. And so we have all these really bad stats. And so the question is, if the hospital is so safe and the appropriate place for everyone to birth, why are our bad stats rising and our good stats are not?
Yeah. And one thing I'll say about that too is like, I mean, I guess, yeah, throughout the history of humankind, women were giving birth to other women. Like it was a woman-centered thing.
Yes.
And it's just so crazy and so sad that it just took like one or two generation of women to lose all of this passed on generational knowledge of how the birthing works. Whereas like if we even wanted to go back to home births and get the hospitals out of it, like all that knowledge is lost, so much of it. So
Totally.
we're kind of at a tough place.
We see the same thing in medicine, right? Like it's the same thing with breech birth. It used to be in the 90s that breech birth was like a normal thing. All skilled providers had it. All hospitals allowed for it. And then it started to slowly die off. And
I just want you to actually just, because you said it before, but just define breeched birth for the listeners.
Oh, yeah. So breech birth, typical babies, most babies are born head down, right? Their head comes out and then their shoulders and their torso and their feet are last. With a breech baby, they're actually head up. And so they might be born with their feet first or their butt first. And so a breech birth is with a trained provider in large part, very safe. The danger comes in when you try to birth a breech baby with an unskilled provider who is not familiar with the way in which you should support a breech birth, which is very different. So remember, with a head down baby, once that baby's head comes out, we can see, are they breathing? Are they moving? Are their eyes opening? When you have a baby whose body is out and their head is still inside, we are evaluating that baby's well-being in a very different way. We're evaluating the umbilical cord. We're evaluating their body movements. The way in which they move their body is very different than a baby who is head down.
Now, I have always been fear-mongered with the fact that you need, if it's a breeched birth, if the baby's upside down, feet first, then the umbilical cord is going to wrap around its neck and it's going to suffocate. Is that valid?
Well, so a nuchal cord could happen with a head down or a head up baby. It's not necessarily associated with one or the other. Just the fact that your baby is in your belly in a water balloon with a cord that is kind of free flowing can wrap around their neck at any time. What we do know is that 1 in 3 babies, so very common, if a provider delivers 6 babies on a shift, then hypothetically they should see 2 nuchal cords every shift, right? If a baby's umbilical cord is wrapped around their neck once or twice, it is almost always non-problematic, and we can simply unloop it, and there you go. With a baby that has their cord wrapped 3 times around their neck, then there are some complications that can arise, and the risk is just higher. Again, it doesn't guarantee that a complication happens, but we do sometimes see with nuchal cords that the umbilical cord is too short to let that baby out. So without that extra, if we're not able to get it over the baby's head and give that umbilical cord the extra length, sometimes we do have to cut it in order to get that baby out, which obviously means you don't get delayed cord clamping. You can absolutely.
So you would just cut the cord. So you still have a vaginal birth. You just cut the cord.
Oh, absolutely. So, well, with a head down baby, right? So let's say the baby's head comes out and you see that there's a nuchal cord around, and let's say that it is wrapped 3 times, and we try really hard. Providers will take their finger and they loop it under the umbilical cord, and they literally slide it over the baby's head like you would a necklace. And if you're not able to do that because of the tension on the umbilical cord, your next step would be to cut that umbilical cord to release the tension so that the baby could slide out. Obviously, asphyxiation is a rare, very rare, but certainly a risk for that as well. And then we do sometimes think about cord compression, because typically the baby's head comes out and then their shoulders come out and then their chest comes out, and you have to think you don't see their umbilical cord until you see their umbilicus, their belly button. At that point, a baby typically is just sliding out at that point. With a baby that their cord is wrapped around their neck, the places where we get a little concerned is that cord being compressed between their neck and the vaginal opening, their chest and the vaginal opening, and the top part of their torso above the belly button, above that umbilical cord. Umbilical cord. Is there any sort of compression of the umbilical cord that would obviously cause oxygen restriction, which can be problematic.
Right. But you're saying that even if it's wrapped 3 times, it still doesn't necessarily call for a C-section.
Oh, gosh, no, not necessarily. I mean, and those things are easily resolved in the birth room. Are they serious? Yes, when it's wrapped 3 times. When it's once or twice, it's usually very non-emergent, and a really confident and comfortable provider will resolve that without any sort of panic. They will simply unloop it, and then you're well on your way to just continuing labor as normal.
That's great. And I guess one thing that from a kid and thinking about hospital births, I always just had the vision of the women on their back with their legs open. Is that kind of over? Are women now allowed to get up and move around, or are they still encouraged to just lay on their back and have a man inspecting in there?
Yeah, I I would say that most women are still encouraged to get on their back. And, stirrups are still widely used, which are a form of restraint, because when a woman is on her back and in stirrups, she's rendered helpless. She's not able to get herself out of that position, which for some providers is really ideal. For the woman, it's less than ideal. We know that being on your back is a position that increases the risk of tearing. Now, some women choose to be on their back because it feels most comfortable to them and they feel very powerful in that position. In those cases, they should be allowed to birth on their back. But when left to their own devices, most women will choose an upright position, mainly hands and knees. Side lying is also a very popular one. And then, believe it or not, standing is a really easy way to push out a baby. You're very grounded in your feet. You have gravity working towards you. You're upright, and you can really take advantage of all of your body muscles standing up. But no, yeah, a lot of providers are still almost mainly comfortable delivering babies on your back. And so what you may see, and we see a lot, is that you push in a certain position. So let's say you push on hands and knees. You're pushing, and your baby's head starts to emerge. You're likely to hear your provider say, okay, I need you to get on your back now so I can deliver your baby, which is so disruptive to the birth process, right? It's very disruptive not only to the physical process, but now you've disrupted the hormones because you've taken that mom out of that, reptilian brain, that really intuitive brain, and made her think about something. But you've also physically moved her body, which is going to impact her hormones. So, you have a couple of choices. If you don't want to get on your back, you can just say no, thank you. You could also look at your provider and say, I'm not moving. And if they say, I absolutely cannot deliver you in this position, I love to just thank them for sharing that with you and say, thank you for sharing that with me. Please get someone in here who can. And then you just simply, you let them know, I'm not moving. And if you don't have the skill set to support me, it's probably best that you get somebody who has the skill set too.
Wow. So how many births do you doula a year?
So it depends on the year, but I've been doing this for about 10 years and I've supported 2,000 families over the 10 years.
It's incredible. So do providers just hate you?
No, actually, they really love me. Most providers are our biggest fan, and actually, our number one referral source in the New England area are providers. We're on all of the hospital preferred providers list, and we hear a lot from women who say, my OBGYN told me to reach out to you and your team. We are very respectful and very collaborative when it comes to being in the hospital space. However, we will always hold the room accountable. So if we see coercive care, we're not saying, oh, Dr. Jones, stop saying that. That's coercive. But what we may say is, Dr. Jones, thank you for sharing that with us. Would it be possible to discuss X, Y, and Z options? Or we might say something like, hey, Maggie, I know that we had talked about X, Y, and Z in your prenatal appointment. Did you want to ask Dr. Jones about that before we move forward with this decision? Or if we see that the doctors are really badgering our client, we may say something like, Maggie, you look very uncomfortable with this conversation. Would you like to pause and take some time to think about this? Or do you have questions that you'd like to ask Dr. Jones before we make this decision? And so it's really collaborative. And I truly do believe that your progressive doctors, they appreciate the accountability, and you can see them slowly unlearning what they learned in medical school, and they start to realize, oh, wow, there's a different way I can present this, or, oh, wow, yeah, that wasn't really the most trauma-informed, patient-centered presentation of that. I should work on the way that I present things to my clients or my patients. And, I love that. I love to help them unlearn the harmful things and to relearn a better way of doing them.
Yeah, that's absolutely amazing. So is there anything that the current medical system gets right about births?
Yikes. I don't know if I've ever been asked that. I think that the current medical system is really, really, really good at identifying when things go wrong. So, for example, a really accurate scan is the 20-week anatomy scan. Because of our advancement in technology, we can see so much in that 20-week scan. However, one of the things that we often see is that they will flag things that are otherwise normal. For example, kidneys. So sometimes you have women who walk away from the 20-week anatomy scan and they've been told, well, your baby only has one kidney, so we'll see you back in 4 weeks to do another scan. And lo and behold, there are 2 kidneys. You just weren't able to see them on the 20-week scan. I wish that instead of saying we didn't find 2 kidneys, they presented it in a little bit of a different manner and said, today, we weren't able to identify 2 kidneys, but we're going to bring you back for another scan, and there's a high chance that it was just today's scan and your baby's positioning. So I don't want you to have any anxiety over the next couple of weeks. Let's wait until this second scan, and then we can talk about options if that second kidney doesn't appear. One of the two that we see a lot is that when it comes to ultrasounds, no one ever mentions that the position in which your baby is in your belly impacts it a lot. And this is baby size. This is the weight of your baby. This is whether we are able to see everything on an ultrasound or not. And so I just think that if we were being super upfront with women, we would tell them that. So yeah, the one thing that the hospital system gets right is that when there is a true problem, a lot of times they're able to fix it. Like fetal growth restriction is a really great example of that. A baby that's measuring too small.
Great. And yeah, as far as like pre-op procedures, is any of the stuff invasive? Like, are ultrasounds invasive? Is there any negative to them or?
Yeah, so the data says we actually don't know long-term effects. So we cannot say that they are either safe nor unsafe because we simply just don't know. There are some things that you can mitigate this risk with. So you could ask the provider to use it sparingly. So one of the things I've done in my pregnancy is I asked my ultrasound tech not to hold the Doppler, the little, I guess, handle thing that they use, the actual ultrasound stick handle, to my belly longer than about 30 seconds at a time. And if she wasn't able to gather the pictures that she needed, I wanted her to take it off and then put it back on my belly, give my baby a little bit of a break. Another thing that you can do is have them start on your leg and use the Doppler up your leg and then place it on your belly rather than just directly on your belly, which some people believe it could be really loud. When you look at ultrasounds, we are not sure the long-term impacts on developing cells and developing fetal tissue. And so that is the thought. Ultrasounds do heat up tissue. And so if we're using it too often or too long, there's certainly a question, a very valid question of, are there any harms or risks to the baby? And unfortunately, we just don't have that data.
Right. But I guess for the diagnostics that you're getting at this point, you do think that the benefits outweigh the risks, but you just have to be careful and mitigate the risks and the usage. Would you ever recommend someone just not get ultrasound?
Yeah, absolutely. I mean, if that person is really hesitant about it and they don't feel like the data that they would gather from an ultrasound would help them make any sort of decision, then the question is, then why get it, right? So a really great question about this is, on the 20-week ultrasound, if you found that your baby was incompatible with life, would that change what you do going forward? Would you stay pregnant? Would you choose to terminate the pregnancy? If for you it wouldn't change change anything going forward and you felt very hesitant or even against ultrasounds, it is very valid to say, I don't want this, because the data that I would gather from that is not going to change the outcome, right? I think ultrasounds are very, very individualized. Some people really enjoy them. Some people are very against them. And then most people just want to use them in a really intentional and smart way.
Gotcha. Is there anything else invasive that they do before?
Goodness, everything's invasive, right? I'm a big proponent of like when you go.
Do you think a blood test is invasive?
I mean, it depends on whether you consented to that or not, right? I think that so here's another example. You're asked to pee in a cup every single time that you go to the provider. It is said to be done for preeclampsia, but then you have cases of women who were tested for GBS, so group B strep, in the first trimester without their consent, and now it has changed the whole trajectory of their pregnancy because they have a diagnosis that they didn't even know they were being tested for. Same thing with drug tests. You have women who did not ever consent to having their urine tested for drug testing, and they test positive for, let's say, cannabis when they live in a state where it is legal, and now they have a DPH case open against them and they never consented to having a drug test. They were never even told their urine was going to be run for a drug test. And so, yeah, I think, again, when you go looking for problems, you're going to find them, especially in a hospital system that's driven by profit.
Yeah, and problems create profit. And
totally.
And I think, like you said, I mean, I think that just the headspace is just so important in general. So you're just kind of messing with that and introducing variables that maybe aren't overly important.
Exactly. Stress, anxiety. I mean, the worst thing that we can do for a pregnant mom is to stress her out. We know that it leads to horrible outcomes: preeclampsia risk, preterm labor risk, fetal growth restriction risk. When that mom has high cortisol, it is bad for her and her baby.
Right. All right. We have 10 minutes left or so. Let's jump forward to the birth itself.
Okay.
We kind of went back. Let's move forward a bit. Okay. So in my like conspiracy channels, I see, you know, they want to cut the placenta immediately because that's got stem cells, and then the hospital sells that and is that real? I hope it's not real. Is it real? It could be real.
You know, this one is really hard to get to the bottom of it. I've never found a provider that will admit what they do with the placenta. They always say they discard it. However, there are documented cases, court cases, where courts have not allowed women to have their own placenta. And it's very strange. And you just have to ask, why? That's her organ. Why would you not allow her to have her own organ? What are you doing keeping it? Why do you want it so bad that you were willing to take this woman to court to prove that you needed to have it, right? Mm-hmm. We also know that most children will never need stem cells. And so the idea of keeping stem cells in like a bank of some sort, there is something to be said of whether it's needed or is it predatory, because it's very much based on fear, right? So we're scaring parents, but what if your child does need this? You should take advantage and have it in a bank. For some people, that feels very good. And they're like, you know what? I am a what if person, and I would never, ever, even on the 0.00001% chance that my child ever needed anything, I want to be able to have the answer. Cool. Bank those stem cells. But for most people, if you don't have, you know, the financial income to just like throw it away on that very, very, very small chance, because it is very expensive to bank these things. It's super expensive. You
can't just put it in your own freezer?
No, so you send it off to a bank, and then depending on the bank that you choose, you may or may not have access to your own child's stem cells. It may be that when you go to get stem cells, they just give you stem cells that match your child but are not your own child's.
That's
Kind of
crazy.
wild. Yeah. Yeah.
But how come
So
you hear about people bringing their stem cells home, their placenta home?
Well, because it's a little ritualistic. And then there are some anecdotal studies that show that if you consume your placenta, usually in the form of capsules, but some people do it raw in a smoothie, or they might cook it and put it in a soup or a stew or some sort of ground beef dish. That it will actually help level out your postpartum hormones. And then there's
Right.
other anecdotal evidence saying that it can help with milk supply. It can help reduce postpartum anxiety, depression, all sorts of things. Of course, that is the funded studies, which depending on how you feel about funded studies, those are sparingly, right? They're not readily available. But anecdotally, millions of women will tell you that consuming your placenta postpartum has helped them drastically. And what we don't know is that a placebo effect, or is it truly, kind of research based? But I'm one that says, like, so what if it's placebo?
Yeah.
Who cares? Like, it still is working.
Yeah, I mean, I'd rather have the person have it than the hospital. So basically, just to go back to what you said, so basically, if the baby needs the stem cells, it has to come from a bank. But if you just take it home, then you just kind of eat it or put it in capsules, and that really more benefits the family or the mom per se. So that's kind of how that works.
Yeah, you can also do a ritual. Some people plant it in their yard. Some people make art out of it. You can cut pieces out and have jewelry made. So there's a lot of ritualistic practices. And then depending on your culture, there are certain ceremonies that different cultures do. Candle burnings, or they might cover it in herbs and use it in a ritual of the way that they dispose of it. There's a lot of fun things that you can do with your placenta. The placenta, fun fact, is the only organ that you grow and then dispose of, and then later in life, you can grow another one. And if you have 5 children, then you can grow 5. And you have 15 children, you grow 15. It's very, very cool.
That is really cool. And so I'd imagine that you're in favor of the delayed cord clamping.
Oh, yes, absolutely. So there's a lot of benefits. The World Health Organization says that we should be delaying for 1 to 3 minutes. ACOG says up to 60 seconds, which is such baloney. We know that most placentas have not drained in 60 seconds. And so your baby is missing out on a lot of their own blood. So you have to think it's a circulatory system. So if you think about a loop, and your baby and your placenta are constantly circulating blood from one another. And when your baby's body exits yours, that circulation gets interrupted, that circle. And so from that point on, you need up to 30 minutes or so for that placenta to drain, detach, and be born. Now, the average placenta, I just had a stat read to me that said the average placenta will be born in about 9 minutes. But I have been to births where it has taken 60 to 90 minutes. And so each placenta is very different. The one thing that we want to consider is if mom's bleeding is okay. So if mom is doing all right and her bleeding is appropriate, then it's arguably that it's appropriate to leave her placenta attached. If her bleeding is not appropriate and she's bleeding too much, then the resolution would involve getting that placenta out, and that would involve usually Pitocin and controlled traction, which is pulling on the umbilical cord to help release that placenta, which the caveat there is that if controlled traction is done by an untrained provider or a provider that's not very good at it, they can actually cause a hemorrhage because they pull the placenta too fast away from the uterine wall, which causes increased bleeding. It's a very intricate process that you have to be very skilled in doing, or you could cause more problems than you do support.
So I didn't realize that. So the placenta, even after the birth, the placenta is still attached to the mom?
Yeah, absolutely. So all
I
the
didn't know
blood
that.
within the placenta is draining into the baby, and that umbilical cord will actually go from like a dark, dark, dark purple, like a blue purple, all the way to a white. And so you'll see it kind of get gray. It'll go from a dark purple to a lighter purple to a gray color to completely white. And that indicates that all the blood in the placenta has now made it back to your baby. And at that point, the placenta will actually start to break away from the uterine wall like this. It starts in the middle and it kind of like breaks away, and then it will be born. And the uterus continues to contract. A lot of people don't think. They think like after the baby's born, your uterus just stops contracting, and that is not true. You will have contractions for many hours after birth as your uterus is continuously clamping down and controlling your blood loss.
Very interesting. Have you ever seen that documentary where they show like a vegan placenta versus a placenta from a woman that consumed meat?
No, what's the difference? What do they look like?
I mean, it's just like one just looked so malnourished. It was like it didn't really have color. It was like almost like gray. Where like the woman that ate meat, it was like dark red. It was full.
Yeah.
So
Yeah.
have you seen that? Like, have you worked with like a vegan or vegetarian?
Yeah, I can't say that I've compared their placenta. I mean, I am the daughter of a cow farmer, so I believe that humans are carnivores. I believe in red meat. I believe that, the propaganda about red meat increasing all these health factors is just that. I think it's propaganda. I don't believe it. But yeah, I mean, that makes sense to me. Your placenta is a very vascular organ. And so if you are going to properly nourish that, you need iron, you need vitamins and minerals. Like we need you to be nourished in a way that you can nourish your placenta. And I definitely question whether veganism or vegetarianism is doing enough of that. If you don't want to eat meat in your pregnancy, that's totally fine. I definitely understand if that's something that you really believe in, but there are other ways that you could get those nutrients in. Maybe you opt for some sort of like desiccated beef liver, or you opt for some sort of iron supplement, but a heme iron supplement, not just any iron supplement. It does matter what kind of iron you opt for.
Yeah. And yeah, I mean, I just think in general, meat sends the body and the brain signals of abundance, which is, what you need to birth a life. So I just,
Totally.
I just can't imagine depriving a child of meat during a pregnancy. But that's a story for another day. We are sort of out of time here. We're at an hour. I would like to do a little lightning round because I had so many more questions that I didn't get to ask. So instead,
Okay.
we'll do it in the form of a lightning round. So
Cool.
Basically, it's just going to be, just a yes or no answer, no explanation needed, and take it for what you will. I'm sure with the next couple questions, there will be a lot of nuance. So I'm not going to give HeHe the benefit of the nuance. You just get to yes or no.
Great.
Don't
Okay.
quit.
This
All
is
right.
where I get canceled.
Exactly. Okay. Erythromycin,
No.
vitamin K,
Yes.
Hep B shot,
No.
circumcision.
No.
Amazing. That's the lightning round. Do you have a hot take for us?
My hot take is that you're allowed to do whatever you want in your birth. You don't need someone's permission. You guys, you're a grown adult. You have free will. You have autonomy. It's literally written in the laws that you get to make decisions for your own body. You are allowed. And I really, really encourage you to take advantage of that.
HeHe, where can people find you?
You can find me on Instagram at Tranquility by HeHe or the.birth.lounge, or you can visit thebirthlounge.com/join and join my childbirth education. And I also have a podcast. It's the Birth Lounge Podcast, and we have nearly 400 episodes.
Thank you so much.
Thank you.
This is the Cold Plunge Podcast with me, Mike Gorman. Be sure to check out the video version of this podcast on our YouTube channel and check the show notes for any references, studies, or links to anything I spoke about on our website at plungereviews.com/podcasts.